Hello, everyone. Welcome to Retina Radar. I'm Arshad Khanani, Director of Clinical Research at CRI Associates and Clinical Professor of Surgery at University of Nevada, Reno School of Medicine. It's my pleasure to have my good friend and colleague join us today, Dr. Carl Regillo, Director of Retina Service at Wills Eye Hospital and Professor of Ophthalmology at Thomas Jefferson University in Philadelphia. Welcome, Carl.
Thank you, Arshad. Great to be with you here today.
I'm looking forward to our discussion. Today, we'll be discussing the current and emerging treatment options that may improve outcomes for patients with diabetic retinopathy. Carl, you being an expert in the field and involved with everything that's been approved and upcoming in the future, we are really thrilled to have you here. But before we get started, we usually start by some personal questions. Tell us a little bit about how did you end up in retina and becoming world-renowned retina specialist?
In my career, it's sort of one thing led to another. I went into ophthalmology just because in med school, that's what it stood out in terms of a field that was most attractive to me. And then it was only once I was in ophthalmology residency, it was the patient care experience and, frankly, some very influential retina mentors when I was training at Wills Eye in residency that attracted me to retina. And I also saw retina as a huge frontier, unmet needs, and lots of exciting research was occurring, but we had yet to have a sort of good command on many of these medical retina conditions like neovascular AMD and diabetic macular edema. We were making progress, but nothing earth-shattering. That all came later, and that also helped me building my career as I continued on in research.
No, I agree. I mean, it's a fascinating field, but I think when you were in training, we did not have anti-VEGFs, correct?
Yes, that's correct. All right. In fact, yeah, I predate even photodynamic therapy, let alone pharmacotherapy. So yes, in practice, when I was in training in early years in practice, it was all about lasers and surgery. And there were no pharmacotherapeutics. The first intravitreal injection for therapy, other than antibiotics, was steroids for DME. We all know what happened thereafter.
Yeah, no, I mean, very exciting field for sure. And we all stand on the shoulder of the giant. So who are some of your mentors at Wills?
I would say on the top of the list was Bill Tasman was extremely influential in my career development, my training, and then, of course, I later joined him. He was the founder of the practice that we now call Mid-Atlantic Retina, which has grown from when I joined. I think I was number sixth partner. Now we're up to about 25.
Wow, yeah, Bill is an amazing, amazing guy. So what are your hobbies, Carl? You are in great shape. You're an outdoor person. So what are some of your hobbies?
Well, I do have a lot of hobbies, a lot of interests. I wish I had more time for many of them, but I would say on the top of the list there is travel. I really like to travel and see the world, and with that is kind of food and wine, and that I think all ties together. I also enjoy skiing quite a bit, and like you said, fitness is a big part of what I do on the side.
Great. No, I mean, I love traveling around the world too. I wish we had more time to travel, right? We're all so busy. So that's why it's important to have new treatment options for our patients so we can actually decrease the treatment burden and stress on our clinic and our staff. And last one, what's your favorite vacation spot?
Oh, actually, I think that's an easy one. Although I love going all over the world, and I've had great experiences, but Italy comes probably number one there.
Great, great. Okay, so you didn't answer the second question, but I'll answer for you. The second question was, how did you become world-renowned retina specialist? I'll tell you why. Because you are amazing to work with. You are smart, you work hard, and you prepare for everything you do. I've done a lot of events with you, and my goal is always to be as ready as you are because you're always ready for game time. And I've spoken to your fellows who say nothing but amazing things about you and how great of a surgeon you are. So it's a pleasure always to work with you, Carl. So let's just dive into the topic at hand, diabetic retinopathy. Kind of controversial topic, right? When we had no treatments for it, people were looking for treatments. Now we have approved therapies in ranibizumab, in aflibercept, 2 milligram and 8 milligram, but still people are not treating their patients with moderate to severe NPDR. Most of us are treating when patients get PDR. So tell us, what is your management of diabetic retinopathy, and what do you think is going on in the US and ex-US in terms of treatment patterns?
Yeah, so when I think of the entire diabetic retinopathy management space, of course, um, I kind of think of it as two buckets, the DME management and then the DR management. Of course, there's lots of overlap, and in many cases, we're treating both simultaneously. For DME, I think it's pretty obvious, first-line therapy. We have highly effective anti-VEGFs now and a lot of choices. As you mentioned, the first-generation agents, which does include on-label FDA-approved ranibizumab, aflibercept 2 and 8 milligrams, and also, of course, the Ang2 VEGF blocker faricimab. So those are all most of what we do in the management of DME. Of course, I mentioned steroids, individual corticosteroids, still an option, second line for the most part, mainly because of side effects, but can work very, very well. Very rarely would we ever use focal laser. I can't think of the last time I did that. And it's pretty much a medical condition, not a surgical condition. But for DR, I think that's the focus of your question. Right now, a lot of it is observation, right? Unless you're dealing with PDR. Of course, PDR, it's going to be anti-VEGF, and to some degree, we still have PRP, which is very useful for very durable stabilization. But it's often some mix, right? Sequential use, anti-VEGF, followed by PRP, maybe not. But you specifically asked moderately severe NPDR. Well, if there's no DME, I think the standard of care, more or less, or what the majority of us are doing, is simply closely monitoring. Why? Because it requires a commitment to do many injections to see improvement or prevention of worsening or prevention of vision-threatening complications. It requires ongoing injections, and really both patient and doctors alike are reluctant to want to initiate a course of injections in an eye that may have normal vision and patients may have no symptoms. So it never really caught on, despite how good the evidence is, how well that actually works. You know, we can point to many studies. All the DME studies show consistently 40, 50% two more step improvements with constant, regular, fixed monthly or every other month anti-VEGF injections, ranibizumab, aflibercept, and then of course you can turn to the Panorama study and Protocol W.
No, I think that's a great overview. Yeah. So the focus here is, DR without DME. Obviously, for DME, as you said, we have great agents. We treat those patients, especially if they have decreased vision and central involving edema. So I think DR is very intriguing, right? Like we know that majority of these patients are going to get worse, especially if they are severe NPDR. Some numbers say 50% or so will progress over 1 year. Even with the new treatments that we have tons of patients, right, who come in with advanced disease, even at this stage. I mean, I just saw a patient bilateral TRDs, young patient, insured also. So I think there's still multiple, gaps and unmet needs. Obviously, getting these patients early enough to our clinic, number one, but also intervening early. And I think as a field, we're looking for sustained delivery options to kind of decrease their treatment burden. I agree with you. I think, asymptomatic patient receiving anti-VEGF frequently for a long time, it's very difficult, especially outside a study setting. Carl, are you treating currently your patients with moderate to severe NPDR in your practice?
So if it's NPDR without DME, the answer is essentially not really. There are exceptions. Um, it should be kept in mind the options to treat DR without DME. There are three FDA-approved agents. Ranibizumab 2 and 8 milligram aflibercept have the indication of DR without DME, or any DR, we'll say. Certainly, I'll consider these medicines for PDR, especially if there's high-risk characteristics and so forth. And what I sometimes do is if I'm treating DME in a patient with pretty high level of NPDR, and I get the DME to resolve, in some patients, I'll stop treatment. I treat DME PRN, but in some of these patients, if they're really severe NPDR, I might keep them on treatment to effectively keep the DR suppressed, prevent worsening, and prevent or decrease the risk of vision-threatening complications. So I might keep them on sort of a every 12-week type of regimen to get that added benefit. I'll tell the patients this is an added benefit of the anti-VEGF above and beyond the DME management.
No, I agree with you. I think I'm managing the patients the same way. Moderate to severe, I usually don't treat. If they have PDR in the other eye or they have DME, then I think it's a different scenario. So I think, we have great evidence, as you said. We have 3 approved agents, but they're not being utilized for DR only without DME. And I think the reason is the treatment burden, right? I mean, the patients most of them have no vision symptoms. They have good visual acuity, most of them 20/20, and convincing them to get injections, the burden of treatment, the risk and benefit, the cost, I think it becomes very difficult. So I think as a field, all of us have been looking at sustained delivery, as I mentioned, and you have been involved with many of the ongoing sustained delivery programs. And obviously, you were very closely involved and are closely involved with the port delivery system, or PDS, which is a surgical device placed in the operating room, was approved for neovascular AMD, was recalled because of septum dislodgement issue. Is back in clinical trials after technical changes. We have great data from the phase 3 Pavilion study, Carl, that looked at patients with diabetic retinopathy. Of course, we also have positive data from Pagoda study, which is the DME study. But let's focus on the Pavilion trial, Carl. What are your key takeaways from that study, and where do you think port delivery system fits in, especially being a surgical device?
Those are great questions because I think when it comes to treating DR without DME, in order to prevent progression and vision-threatening complications, it's going to have to be a sustained delivery platform in general. And PDS, of course, is one option or potential option. It's not FDA approved yet for DR or DME, and it is coming back. We expect it to be coming back on the market for wet AMD in 2024. And it could very well be FDA approved for both DME and DR. So where does it fit in for DR? Well, of course, as you mentioned, it's a surgical procedure. It's also a device. And so you have to weigh those potential adverse events that are unique to that device that we've seen in all the studies. And I'm going to address that first, because if you just look at efficacy, you're blown away, actually, by how good it worked. 2 anti-VEGF injections up front, followed by the implant at that time, and then refilled 9 months later, so only once over the course of a year. And we're talking 80% to or more step improvement. Really nothing has come close to that other than in Panorama, very frequent 2 milligram aflibercept came about 80% at year 1. It took 9 treatments, though, to get there. So here we have sustained delivery with a little bit of a boost up front with 2 injections, getting that same level of efficacy. You'd say, wow, that's a no-brainer. But you have to weigh the adverse events. There is technically slightly increased risk of endophthalmitis, although in the Pavilion study, there were no cases of endophthalmitis up to the primary endpoint. And actually, the adverse events, we're seeing some definitive trends for lessening of adverse events related to the device. There were no dislocations in the study. There was 1 retinal detachment, but again, no cases of endophthalmitis. And it could very well be that the younger patient with thicker tenons and conjunctiva, we might have less conjunctival issues and therefore less cases of endophthalmitis. So it may actually be better suited, or let's say better tolerated in this relatively younger patient population. I mean, I really think it's a dialogue with the patient. I don't think this is going to be something we're going to do routinely, but in selected patients with pretty severe NPDR, it's going to be an option.
No, I agree with you. I think, unless you do the surgery and see those patients afterwards, it's very hard to kind of imagine doing a surgical device for a disease which is which is going to progress. But currently, patients have good visual acuity. So I've had multiple patients be enrolled in the Pavilion study, and they're all doing well while their fellow eyes start to get vision-threatening complications or DME, and then you have to start anti-VEGF. So I think your point is valid. It's a surgical device with a subset of risk, even though we have obviously done a great job with learnings, from the past in terms of optimizing the surgical procedure. It's a risk benefit discussion with the patient. And, as physicians, we tend to be conservative, obviously. And when I was enrolling in the Pavilion study, I thought patients are not gonna want it, but we end up enrolling a good number of patients. And many of them are getting monthly or every other month injections in the fellow eye because they got DME or other complications. So I think patients realize the value of it. So I think it's one of those things that is going to be driven by patients and physicians discussing the risk benefit profile. But yeah, the efficacy data is unbelievable, as you said.
When we talk about all these interventions for DR, um, we know that the primary endpoint could be 2 or more step improvements. I think people need to realize, and patients, of course, too, that that's directly correlated to a very significant lessening of vision-threatening complications, which is defined as either center involving DME or PDR-related issues, vitreous hemorrhage and TRDs and so forth. So and that's really what matters to the patient. So it's important to look at all these outcomes. 2 more step improvement, which is great, but even 2 or more step worsening is important because you don't want to go from NPDR to PDR. And then these VTCs, vision-threatening complications, I think is really what matters to the patient.
Yeah, and what do you think matters for the physicians? Like, what is your goal? Do you want to hold the patients where they are so they don't get VTCs, or would you like to see two-step improvements? Personally, for me, two-step is a regulatory endpoint, but my hope is that if I have a moderate severe NPDR patient, if I can hold them there and not get vision-threatening complications, then I think that's a success. What are your thoughts on that?
Totally agree. In fact, I'd like to see VTCs as an acceptable endpoint. 2 or more step worsening is, so that's useful. But nonetheless, what really matters, as you says, is VTCs. That's why would a patient want to get preventative or prophylactic treatment? Be proactive to hopefully decrease the risk of vision loss, either temporary or permanent, and or the need to do many treatments to control these types of complications.
No, I totally agree with you. So let's shift some gears here. Carl, gene therapy, very exciting. We have multiple programs looking at wet AMD, and we have one program with ABBV RGX-314 looking at DR with suprachoroidal in-clinic injection. This is a one-time injection. AAV8, has the transgene similar to an anti-VEGF fab like ranibizumab. This trial has been active for past few years, has shown promising data in terms of controlling or stabilizing DR. Can you tell us a little bit about the study outcomes and implications on the current treatment paradigm if RGX-314 is approved for DR?
Well, just the approach here is super attractive. Um, there's no downside to suppressing VEGF in a patient with diabetic retinopathy indefinitely. We know that going way back to Ride and Rise, monthly ranibizumab for 3 years, no downside, only benefits. So we don't have to worry about that. And so this is a potential one-time office space, so no device, no surgery, and the safety profile. You notice I'm talking safety first. Safety profile is really very good. A little bit of intersegment inflammation at higher doses, nothing that topical drops can't suppress. Doesn't look like it's a long-term issue. This is being tested at a phase 2 level, 3 doses, suprachoroidal, as you mentioned, and that's a pretty straightforward thing. A little more nuanced, not quite as easy as an intravitreal injection, but any retina specialist can do it. We have an approved type of product that's administered in that fashion, so many retina specialists already have that experience. And what does it show for efficacy? Well, I think in showing some encouraging things. It's probably not quite as impressive in the 2 or more step improvement department. We haven't seen the highest dose level yet, so I think that's going to look better. But we are seeing a bit of a dose response, and we're seeing some improvement in the majority of patients in the second dose level compared to the first. And we're seeing also as you pointed out, an important aspect of no worsening or very little worsening, depending on the dose. So that's where I think, again, the benefits are going to come into play here with the use of such a product. But one and done for a patient, I mean, and it's technically less invasive. It's not directly intraocular. So this is something to watch for sure.
No, I agree with you. I think very exciting, the one and done. I think the benefit there is that many of our diabetics get sick. They miss appointments, they have treatment burden for other systemic issues. And I think if you can safely do a gene therapy in clinic for DR and stabilize the disease. So I agree with you. I think the two-step data is not wow like the port delivery system, but I think the two things you mentioned, the vision threatening complications, and then also like stabilization versus worsening in the control group, kind of points towards the fact that this clearly has biological activity. So hopefully we go into phase 3 trials in the near future and we can have generate some data so we can have this possible option approved for our patients. So next one, Carl, I know you're also closely involved. It makes it easy when you're involved with everything. Tyrosine kinase inhibitors, right? So we have three kind of tyrosine kinase inhibitor in mid-stage to late-stage development. OTX-TKI, which is extended implant. We have EYP-1901, which is Rolanib implant. And then we have CLS-AX, suprachoroidal, tyrosine kinase inhibitor. It's also extended, but it's delivered suprachoroidally. Focus here is DR. So we recently had the data from the two of the programs, OTX-TKI, and from EYP-1901. So Helios phase 1 study with OTX-TKI and Pavia study with EYP-1901. Can you share with us some of the top level findings from those two studies, and then give us some input on, do you think that they have a potential path forward in terms of being an option for patients with DR?
Yeah, this information is limited and all very new. The two programs, OTX TKI and EYP 1901, have been tested for DR without DME. Um, the OTX trial is very small. It's only a phase 1, the Helios study. 21 patients randomized 2 to 1, 40-week endpoint, definitely showing something of a benefit here. Um, Again, not quite as impressive as me doing 9 anti-VEGF injections, but we're seeing about half the patients having one or more step improvement. We'll say no worsening there. There was no worsening actually in the group through week 40. Small numbers here again. So, and we also know that reading centers is a little bit challenging to be precise with DR with the diabetic retinopathy level determination. That can vary a little bit, hard to interpret. But 2 or more step improvement, 2 out of 13, approximately. Again, not so great in the improvement department, but I do like the fact that there's no worsening. And these are very well to these, meaning the TKI bioerodible intravitreally injected inserts, both OTX and EYP are very, very well tolerated. Um, Super rare to get IOI and things like that. And we're getting about 6, 9, maybe even 12 months of a potential therapeutic level with this approach. So I do like it in the sense for treating DR without DME. I think of this, and even gene therapy is at the very least a nice sort of safety net, if you will, for patients. We know these products, gene therapy, TKIs, are not going to eliminate anti-VEGF treatments. Patients will break through. Patients will need anti-VEGF from time to time. Now let's talk EYP 1901. That was the little larger phase 2 Pavia study, 3 arms, and here 2 doses, 3 milligrams, 2 milligram inserts versus control. Shorter endpoint, 36 weeks, and that's important because we'll get some additional information because with time, the control arm will tend to worsen more. And again, not a wow factor here, but we're seeing something, especially in the lessening of the worsening department. And as time goes on, I think we're going to see separation of treatment versus control arm. So when it comes to, for example, two or more step worsening. There was none in the high dose. There was only 10% in the control group. So that's where I think over time, as we get into weeks 40, 52, we might see some of that benefit. Path forward, possibly. Again, depends on endpoints and how a registration study is going to have to be designed here. Yeah, I mean, your thoughts too. This is a harder one to call.
No, I mean, I agree with you. I think we have seen biological activity. We know TKIs are not as potent as pulsatile injections, but we are seeing the signal. As you mentioned, I think the longer term data is important. And, recently the Helios study, they shared 48-week data at clinical trials at the summit. And that number, as you mentioned, at 40 weeks now, at 48 weeks was 1% of OTX treated subjects at two-step or greater DRSS improvement versus zero with sham, and then zero, in the OTX arm showed worsening in DRSS compared to 25% in the sham, and then zero patients in OTX developed PDR or central involving DME. So VTCs by week 48 compared to 37.5 in the sham. So I totally agree with you. I think stabilization, stopping or decreasing vision threatening complications. I think we are seeing biological activity here. And I mean, it would be nice that we have moderate to severe NPDR patients. We are seeing them every 4 to 6 months. Introduce something that can last 6 months or longer, it may be beneficial. So I agree with you. I think it's great to have different options for our patients. And there may be some patient who want a surgical implant, there may be patients who want gene therapy, or there may be patients who just want a simple injection, right? And as you said, safety is a priority, and we have not seen any safety signals here. So I agree with you. I think, going forward with these programs to have potential options is the key. So, Carl, I think to summarize our discussion, I think we have great options for DR. We are not utilizing because of treatment burden and risk benefits. It seems like there is a lot of exciting things in the pipeline that both you and I are involved with, and I'm hoping that multiple of these options, get approved, so we have hope for our patients. Because nothing frustrates me more than seeing a patient I saw 2 years ago with moderate to severe NPDR. Patient disappears, showing up now with poor vision in both eyes, with tractional retinal detachment. And you ask the question, what happened? They got sick, they got dialysis, they got put in a rehab facility. So it's very frustrating, right, as physicians to see these patients lose vision while having good treatment. So I think these new modalities will clearly address that. What are your thoughts?
No, I agree. I think it's highly likely we're going to see one of these approaches, one or more of these approaches, um, in our clinics in the future. I think they have the potential to really offer some great benefits and probably will expand the types of patients we treat.
Very well said. So, Carl, before we close this, we always ask a couple of extra questions about your career. So, tell us, what career achievement are you most proud of? I know you have had a great career and a lot more to go, but and won so many different awards. Tell us, what is something you're most proud of?
Well, I'm not sure I can think of one particular. Certainly, it's great to be recognized, and the awards are very meaningful. But I'm going to say it's probably a combination of making an impact on a local level with patient care and fellow training, retina fellow training. And then on a larger scale, doing the things we all do, you included, which is to help the field advance through collaborative, large scale clinical trials and testing, putting these new products to test.
Yeah, you have had so many successes, right? So, I mean, I've met many of your fellows, as I said earlier. I think they all love their training. They were really inspired by what you have done for them. So I think, training fellows is a very exciting thing. I've trained a few so far, and it's very rewarding to see them coming in, not able to do surgery, and walking out great surgeons, and helping them help patients, right? So I agree with you. I think it's something you should be very proud of, that you've trained so many fellows. And then last thing, how do you want to be remembered? Once you retire? I know you have a lot more time to go, but tell us how you want to be remembered.
Well, first and foremost, I think it's have made an impact, of course, at some level here. And the things I mentioned that I'm most proud of, what I'm probably not going to be remembered as is an innovator or an entrepreneur. That's just not my wheelhouse. But maybe I'm hoping it's more of a critical thinker who spent my career studying ways to make outcomes better for these common blinding conditions.
And I think you have already are remembered. On top of that, obviously you're great to work with. As I said, I've never seen you upset. You are such a pleasure to have as a colleague and a friend. So thank you, Carl, for excellent discussion. And thank you to the audience for listening in. Please remember to take the post-test and evaluation to receive CME credit and to tune in for additional episodes within the podcast series. Thank you, Carl.